Hello, doctor and friends. We are from HEDB2 and now we will explain about chemotherapy-induced cardiomyopathy. This is our group member. Now we will go to chapter 1. First, let me introduce myself. My name is Natania Faustine with the last three digit number 158. As the proof of cancer research and development advancement, chemotherapy still have their limitations and consequences. One of the most common side effects of chemotherapies is chemotherapy-induced cardiomyopathy. Chemotherapy-induced cardiomyopathy is the development of heart dysfunction due to intensive exposure to chemotherapeutic agents. It has become a significant barrier to successful treatment of cancer and the long-term well-being of patients. The incidence of cardiomyopathy due to chemotherapy agents is ranging from 5 to 65%, depending on the criteria used. The severity of chemotherapy-induced cardiomyopathy is correlated to the regimens of chemotherapy, patients' populations, and durations. It can occur either at the early stage or late stage of the cancer treatment. The most common drug of choice causing chemotherapy-induced cardiomyopathy are anthracycline and trastuzumab. While these medications are instrumental in combating malignancies, their cardiotoxic effects pose significant challenges in managing cancer survivors' long-term cardiovascular health. As the number of chemotherapy-induced cardiomyopathy is crawling up, the therapeutic opportunities of cancer patients will become more limited. Next.
Hello, doctors and friends. My name is Novea Indratmo, and the last three digits of my student number is 119. Based on the background, now we can set some problem formulations as the following. First, what is the definition and etiology of cardiomyopathy? Second, what are its signs and symptoms? Third, what are the causes of cardiomyopathy in cancer patients with chemotherapy medication? Fourth, what is the pathophysiology of chemotherapy-induced cardiomyopathy? Fifth, what are risk factors? Sixth, how to diagnose and test for it? Seven, how to treat, and eight, how to prevent it. Now, based on the problem formulation, we can set some objectives. The first is to understand the definition and etiology of cardiomyopathy. Second, to understand the signs and symptoms of cardiomyopathy. Third, to address the causes of cardiomyopathy in cancer patients with chemotherapy medication. Fourth, to understand its pathophysiology. Fifth, its risk factors. Next, it's to how to diagnose and test for it, how to treat it, and also how to prevent it. Now, there's a lot of benefits from this study. The first is to advance our understanding towards chemotherapy-induced cardiomyopathy, which is including the definition, etiology, signs and symptoms, causes, pathophysiology, risk factors, diagnosis, treatment, and also prevention. Second is also to raise awareness about this condition and also, of course, to apply this knowledge in our clinical applications later. That is all from me. Thank you.
Hello, my name is Desylia with your last digit of student number 084. I'm going to explain about definition and etiology of cardiomyopathy. So, cardiomyopathy defined as a myocardial disorder with abnormal structure or functions of myocardium in the absence of definite disease able to cause the myocardial pathology. According to morphology and functional aspect, there are four categories of cardiomyopathy, including dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and also arrhythmogenic right ventricular cardiomyopathy or dysplasia. So the next one about the etiology of cardiomyopathy. The first one, dilated cardiomyopathy, may be caused by hypertension, coronary artery disease, and genetic predisposition. And then the second, hypertrophic cardiomyopathy in adults, mainly caused by 11 genes mutations. And then in children, may be caused by neuromuscular disorder and idiopathic myocarditis. And the third one, restrictive cardiomyopathy, may be caused by amyloidosis and sarcoidosis. And the last one, arrhythmogenic right ventricular cardiomyopathy or dysplasia, may be caused by inherited illness affecting the right ventricle's muscles that is dominantly autosomal. That's all from me. Thank you.
My name is Elizabeth Thalia with the last three digits of my ID number 211. So now I'm going to explain about the signs and symptoms of cardiomyopathy caused by chemotherapy. So the first one is signs. Signs are objective findings that can be found on physical examinations. One of the most common types of cardiomyopathy caused by chemotherapy is called dilated cardiomyopathy. In this case, the ventricular walls become thin, causing the left ventricular muscle to dilate. The abnormalities found are decreased left ventricle ejection fraction, which means the blood cannot be pumped out of the heart appropriately. The second one is S3 heart sounds, which happens because the dilated left ventricular leads to dysfunction in the mitral valve and causing mitral regurgitation. The third one is arrhythmia, which can occur due to systolic dysfunction from the left ventricle. Next is symptoms. Symptoms are subjective findings reported by the patients. And in the patients with cardiomyopathy, the heart cannot regulate the circulation effectively, causing symptoms of heart failure, such as shortness of breath, which occur because of the pulmonary edema caused by the weakened heart muscle. The second one is swelling. So the fluid buildup described previously can happen not only in the lungs, but also systemically. When this happens, there will be peripheral swelling or edema. And the third one is fatigue, which happens when the heart cannot pump enough blood so that the oxygen's need are not met in the body. Therefore, the body's organ tire easily when working. That's all from me. Thank you.
My name is Stella Angeline Isbianto, and my last three digits of student ID number are 142. And now I will present about anthracyclines. Anthracyclines are chemotherapy drugs derived from streptomyces and can be used to treat a wide range of cancer, such as leukemias, lymphomas, sarcoma, and etc. And the most common anthracyclines used in clinical settings are doxorubicin, daunorubicin, epirubicin, and idarubicin. Although anthracyclines are still frequently used in clinical settings, it is well known that anthracyclines can be cardiotoxic, and the cardiotoxicity often presents as arrhythmias, ECG changes, especially change in the frequency of QRS complex, or as a cardiomyopathy leading to heart failure after a long treatment. And patients treated with anthracyclines who is younger than 5 years old or older than 65 years old, have pre-existing heart disease, have previously or concurrently experienced chest irradiation, or have other recognized cardiovascular risk factors, have an increased risk for cardiotoxicity.
Hello, my name is Yovilia Tio Yunus and my last digit of student number is 035. Now I will explain about trastuzumab. Trastuzumab is a monoclonal antibody targeted at human epidermal growth factor receptor 2. In around 25 to 30% of patients suffering from metastatic breast cancer, the gene HER2 located on chromosome 17q is amplified and results in overexpression. This causes the growth and division of cancer cells to become faster. However, the use of trastuzumab in daily clinical practice resulted in the discovery of unexpected off-target effects on the cardiovascular system. It is known that trastuzumab can cause cardiotoxicity, which is commonly seen as a decrease in left ventricular ejection fraction. Next, I will explain about other chemotherapy agents which can also cause cardiomyopathy. The first one is cyclophosphamide and ifosfamide. The next one is paclitaxel and docetaxel. The next one is bortezomib. The next one is lapatinib and sunitinib. And the last one is bevacizumab. That's all for me. Thank you.
My name is Sukawati and my name is 252. So, anthracycline-related cardiomyopathy is a complication associated with the use of anthracycline chemotherapeutic agents such as doxorubicin, daunorubicin, and epirubicin. There are some mechanisms have been proposed, and free radical formation is one of the most studied mechanisms. So, myocardium is more vulnerable to free radical damage than other tissues because it has less superoxide dismutase and catalase activity, and doxorubicin inhibits glutathione peroxide, its primary defense against free radical damage. Superhydroxide free radical gather and develop severe lipid peroxidation, resulting in substantial damage to nucleic acid, mitochondrial membranes, and endoplasmic reticulum. Circulating pro-inflammatory cytokines have been linked to anthracycline cardiotoxicity. Doxorubicin causes macrophages to release histamine and tumor necrosis factor A, whereas monocytes release interleukin 2. These cytokines have functional receptors in the cardiac muscle, and their release may cause dilated cardiomyopathy. Anthracycline-induced ventricular dysfunction may be caused by adrenergic dysfunction and decreased myocardial histamine and beta-adrenergic receptor function. That's all from me. Thank you.
Hello, my name is Aurelia Tabina Wigianto with the last three digit of my student number is 081, and I will explain about the pathophysiology of trastuzumab-related cardiomyopathy. The exact mechanism of trastuzumab-related cardiomyopathy is not fully understood but likely involves several pathways. One key mechanism is the induction of apoptosis and cardiomyocytes via trastuzumab interaction with the HER2 receptor, crucial for heart function, leading to reduced left ventricular ejection fraction and potentially heart failure. Additionally, trastuzumab can activate the immune system, prompting the release of inflammatory molecules like TNF-alpha, IL-6, and IL-1, which can cause heart inflammation and scarring, further impairing heart function. Research also suggests that trastuzumab treatment may diminish key cellular function in heart muscle cells, such as ATP-linked respiration and glucose uptake, possibly by altering gene expression like PGC1A and promote inflammation in the heart, leading to fibrosis and adverse tissue changes. That's all from me. Thank you.
My name is Kusuma Mulya with the last three digits student ID 151. Here I would like to present the risk factors of chemotherapy-induced cardiomyopathy. So the first one is anthracycline related. There are several risk factors. The first one is hypertension, diabetes mellitus, obesity, pre-existing cardiovascular risk factors, age below 18 and more than 65 years old, increasing cumulative dose or dose intensity of anthracyclines, mediastinal radiation therapy, and female. While trastuzumab, they have several risk factors. They are hypertension, diabetes mellitus, previous anthracycline use, elderly age, obesity, history of heart disease, and concomitant use of certain medications.
Hello everyone, my name is Veronika Wijaya with my three last digit of my student ID number 113. Now I will continue the presentation about diagnosis and test of cardiomyopathies. Diagnosis involves a comprehensive process such as patient history emphasizes symptoms like exhaustion, shortness of breath, chest pain, and family history of cardiac issues. Next, physical examination assesses vital sign, heart sound, and sign of fluid retention. And then the test of cardiomyopathies or diagnosis test. Electrocardiogram (ECG) detects irregular rhythms and provides insight into heart electrical activity. Echocardiography uses sound waves to evaluate heart anatomy and physiology, identifying anomalies. Cardiac MRI or CT scan provide detailed image of the heart to identify structural abnormalities. Next, cardiovascular biomarkers. B-type natriuretic peptide, troponin, is a blood test to measure myocardial injury and strain. And the last one, myocardial biopsy, occasionally necessary to examine tiny tissue sample for accurate diagnosis. That's all from me. Thank you.
Hello, my name is Komang Ayu Widhiani and my last 3 digit of student number is 044 and I will explain about the treatment of chemotherapy-induced cardiomyopathy. As you can see in the picture, cardiac risk factor modification and preventative measures should be considered for all patients undergoing potentially cardiac damaging chemotherapy. And next is pharmacology. Once diagnosed with cardiomyopathy, the use of beta blockers, ACE inhibitor or angiotensin receptor blocker, as well as statins, along with regular monitoring, has been shown to improve the prognosis. Beta blockers are recommended for all patients with current or previous left ventricular dysfunction unless contraindicated. Bisoprolol, carvedilol, and extended-release metoprolol succinate are the agents of choice in this class. The combined use of beta blocker and ACE inhibitor has also been shown to have additive cardioprotective effects. In patients who cannot tolerate ACE inhibitors, the use of angiotensin receptor blocker has been shown to provide similar benefit in terms of morbidity and mortality, and is therefore recommended as a replacement for ACE inhibitors. And the use of statin is recommended in patients after myocardial infarction. Next is device therapy. Assistive device therapy should be considered in accordance with guidelines applicable to patients with heart failure in general. Device implantation in patients is currently indicated as in other types of heart failure. Discontinuation of chemotherapy may be an option in certain clinical situations, with recovery of left ventricular function being the determining factor. Discontinuation or delay of chemotherapy often depends on various factors, including the severity of cardiotoxicity, severity of clinical heart failure, cancer prognosis, and the availability of the alternative cancer therapies that have a lower risk of cardiotoxicity. For patients with refractory advanced heart failure, advanced therapies such as long-term mechanical support and heart transplantation may be considered. That's all from me. Thank you.
My name is Nibbana Siva with class digit 121 and this is the prevention of chemotherapy-induced cardiomyopathy. Dose regulation, age at exposure, sex, just radiation, cardiovascular disease risk, and genomic variants modify this dose-response relation are the main focuses to reduce the risk of drug-related cardiomyopathy. Several ways to reduce the risk of drug-related cardiomyopathy includes therapeutic modification. The simplest strategy to reduce cardiotoxicity risk is to reduce the dose of the drugs. Then, therapeutic modification plans that can be carried out are giving analog drugs that have less cardiotoxicity, such as giving liposomal encapsulated doxorubicin instead of the conventional one. Additionally, longer anthracycline infusion duration proved to be cardioprotective, and adding a cardioprotective agent like dexrazosan is also favorable. Another prevention for patients who have already consumed anthracycline is to give early initiation of angiotensin converting enzyme inhibitor or beta blocker to prevent the progression of the disease. Several studies also stated that neurohormonal antagonists such as angiotensin converting enzyme inhibitor, angiotensin II receptor blocker, and beta blocker have beneficial function to prevent cardiomyopathy by blocking renin-angiotensin-aldosterone system and sympathetic nervous system.
First, let me introduce myself. My name is Putri with relation number 005, and today I will present the conclusion of our student project. So, cardiomyopathy is a heart muscle disease that can affect the structure or function of the myocardium, and the symptoms include shortness of breath, fatigue, and swelling. Meanwhile, the signs include decreased left ventricle ejection, S3 heart sound, and arrhythmia. Cardiomyopathy can be caused by various factors, and it's including chemotherapy. Anthracycline, a chemotherapy, can cause cardiomyopathy due to the mechanism of inhibition of glutathione peroxidase and releasing pro-inflammatory cytokines. Meanwhile, trastuzumab can cause cardiomyopathy due to trastuzumab can trigger the apoptosis in cardiomyocyte and also trigger the release of inflammatory molecule. And there are some risk factors that can increase the susceptibility of someone receiving chemotherapy to experiencing cardiomyopathy, which is hypertension, diabetes, obesity, and etc. And to diagnose cardiomyopathy induced by chemotherapy, it needs a thorough process. And for the treatment itself, it can use beta blocker, ACE inhibitor, and angiotensin II receptor antagonist. And to reduce the incidence of chemotherapy-induced cardiomyopathy, some prevention can be taken. For example, reducing the chemotherapy dose. For the recommendation, there are several things that are suggested by the writers. More research should be done on chemotherapy-induced cardiomyopathy. As has been mentioned on the paper, there are still exact mechanisms of chemotherapy-induced cardiomyopathy that cannot be fully understood yet. And thus, further studies should aim to refine and improve knowledge of chemotherapy-induced cardiomyopathy, mechanism, and treatment. So that's all from SGDB2. Thank you for your attention.